Good afternoon, everybody. I'm sorry to jump in. I have a session starting in the next room. So I'll be sharing my experience of phakic lenses, very long follow-up, very high number of lenses which we've done. And we've practically done these phakic lenses in any kind of power I could get my hands on, any size of lens which I could figure out. And in many situations where I guess there was no other option available but to put in a phakic lens, and we had the lens available manufactured to the requirement. So I have no financial relationship for any of the products I'll be talking about. There are various options available for us, but I'll be talking about an IPCL because that's the largest experience I have. That's how the design of the lens is. So whenever we talk about the length of the lens, it's the diagonal length. It's not the linear or horizontal length. So we are talking about the diagonal length. So when the size which you get on the box is this length. Very, very brief exclusion criteria. There are some things which I've mentioned which are highlighted. Sometimes if you don't dilate the patient completely, you may miss some lenticular sclerosis or lenticular changes. These are the cases where I would say no to these patients and go in for a lens extraction. Clear lens, lens rise more than 600 microns, I would definitely want to have more than 3.1 millimeter of anterior chamber depth, at least if I have a higher CLR. Angle from 0 to 180 has to be more than 35 degrees, at least in my experience. Otherwise, you do land up with situations. Keratoconus patients do not get fooled by the very deep anterior chamber. The angle becomes very, very important in these keratoconus patients. So because you have a steep cornea, you can have a false anterior chamber depth. We've done nearly 4,000 cases. So this is the statistics of that. I'll just go fast. The major issues we've had were probably first with the V1 model. Whatever little cataracts I'm documenting here are because with the V1 model, the advantage with the V2 model is that it has an inherent vault by itself. It doesn't need to rest on something to develop a vault. So inherent vault approximately will be a 400 resting vault even if you keep the lens on a flat surface. So the chances of this lens touching the anterior lenticular surface are very, very remote. Number two, the size of the central hole is huge, so the aqueous flow is not compromised, further reducing your induction of cataract. So redialing was done in cases wherever there was issue with the initial marking till we got our nomograms right. I've had patients who have developed retinal detachment and had to have a silicone oil. Of course, they developed cataracts. This is just a small study we did a couple of years ago, 300 patient subset. Majority of the patients were falling into the size of 12.5 millimeter and above, which is 97% of patients. The vault, majority of the vault which we saw was, the 70% plus vault was landing within the required area. But one big plus point is I also have patients with 1100 vault or 1 millimeter vault, and they're doing fantastically normal because of the design of the product itself. So very, very high vaults also the lens is tolerant. And I have seen that with this particular lens, you can rarely go wrong to have a very low vault until and unless your CLR was very high. So if you're keeping your eye on the crystalline lens rise, you can't go wrong. Vision, amazing results, especially with astigmatism. And I don't think I'll mince my words. My response with high astigmatism with this particular lens is very good because of the stability of the lens. And secondly, with the smart category, which, the lens, you don't need to dilate. All you need to do is a good marking of your 0-180 and you get fantastic results. It is available in very, very large sizes. I have actually put lenses which have gone up to 8.25 millimeter optic zones in patients who have very, very large resting corneas. Huge number of powers I put till -34. I put astigmatic corrections till -14 now in corneal scars. This is how the design of the lens varies from the other lenses in the market. It's not a straight truncated design. It's a slanting design which reduces the diffractions and glares and halos. The power availability is huge, but again, you can get the lenses customized, made to the power you want. That is the best part. I have got lenses made to the size of 4.5 millimeter. I will be showing you some videos. The lens, all you need to do is put it at 0, 180. So that's a big advantage. You don't need to refer to any chart. You don't need to do extra markings. You don't need to resort to any other gimmickry. Few things I must mention. Even for my ICLs, I see what is the resting pupil size and what is the maximum dilatation I have. Because what is the maximum dilatation I can achieve with mydriatic also is very important, especially for a beginner surgeon. Let's say you have a 13.25 millimeter or a 13.5 millimeter lens to put into a patient who's not dilating properly. So that can be very tricky, especially if you're a beginner surgeon. Number two, what is your resting pupil size? If your resting pupil size is, let's say, 6.5, 6 or 7, then you are looking at a slightly larger size, even if you take into account the 25% of magnification at the condylar plane. So you definitely mention the large pupil size when you're booking your order so that you can work around it. The learning points I have noticed is I do not put any meiotic in the surgery during the surgery, because I've realized first it gives me a very wrong false vault within first 1 or 2 days. It gives me a shallower vault. Chances of having an intraocular rise are higher because the retained viscoelastic is there. And one thing I've noticed is that once the effect of the pilocarpine disappears, the vault goes up by 150 to 220. And if you dilate the same patients, the vault goes up more by 150. So in few cases where I've had a low vault and I've ordered a new lens and I'm waiting for the lens, I keep the patient dilated. And I have a resting vault of 350, 400. Like suppose I have a vault of 170, there's a problem with the measurement or something wrong has happened. I dilate the patient, tell the patient, okay, wait, and I put the patient on a mydriatic. Meanwhile, the lens comes in. So once you dilate the patient, the vault goes up. So vault goes up by 150, 200, and that's a sure shot thing because we've done a measurement for that. So that's a big plus point here. First few hours, some patients may show IOP spikes. So we, as a routine, once we do any phakic lens, we have the patient sit for 1 hour or 2 after discharge, and before they go, they are. So keratoconus, you have to be very careful. I've already mentioned. The angle, as I said, approximately measurement we've seen goes down by 15 degrees, 12 to 15 degrees. The angle may go down once you put the lens. When you're putting a toric lens, I use a trick. The best part about the lens is it's available in a shift of 0.25 millimeter, unlike other lenses. So you can actually fine tune the placement and what you want. So in a toric, if I have a good anterior chamber depth, I do plan a higher vault. I plan a tighter fit because I want the rotation to be very secure. I don't want any rotation. So this is a trick I often play. I'll skip these videos. These are normal videos. I think we'll go to something more interesting. Now, suppose you have a very large pupil. Do not overinflate with viscoelastic. Otherwise, you'll stop seeing the pupillary edge. So this is exactly what is happening here. I will just come out, release some viscoelastic, and then I'll start seeing the pupillary edge. So in case you have a very large pupil at dilatation, it's a good idea not to overinflate the anterior chamber. Once you have reduced the viscoelastic in the anterior chamber, so I'm just sharing a few interesting concepts and videos which I have developed over time. Now this is one case where one of the haptics has not folded out completely. I'll fast forward. So you put, now in this particular case, I put slight amount of meiotic, I put some viscoelastic on the top, and then I push it in the center. But before I do that, I make sure I rotate the lens 10-15 degrees each side. So that thing unfolds. Sometimes you can have one of the haptic which is not unfolded. So then you can get stuck up. Keratoconus patients, if I'm anticipating some changes in the angle, most of the times I go in, I do either a surgical iridotomy or I do a YAG iridotomy, especially in my keratoconus patients, because I feel, this gives me some sense of security, because I have burned my fingers in 1 or 2 cases. So what I do is I do my irrigation aspiration first, and only in small amount of viscoelastic, only in the area where I want the iris to be pushed back. I go there. So this saves time for me. I just go there and create a PI, and the situation is over. Now this is what in case if you have to explant the lens. So I've demonstrated this hook technique, and it's followed by most of the people who do write to me on the social media that they use it. It's very simple, because the advantage being this lens has got so many holes, you can engage any one of those holes, go with a blunt instrument, engage the hole, pull the lens into the wound, and you can pull the lens out of the same original wound without dilating it. So we'll just see that. First trick is to make the side port. Instill viscoelastic, first coat the endothelium, then instill viscoelastic underneath the lens. I've opened the old wound. I've not enlarged the wound. I've just opened my old wound. Now I instill some viscoelastic underneath the lens, so this viscoelastic starts lifting the lens. And the moment the lens is lifted up, I'll just fast forward, I just disengage it, bring it out from this side, and now I go from the main wound, I engage into one hole, I'll engage into the hole and hook it and pull it into the wound and leave it. Now you can use a needle holder. Do not use a tooth forceps. It will break the lens. Use a needle holder or a McPherson and pull it out and it's over. It is out in 10 to 15 seconds. Now in case you have a high intraocular pressure which has gone up, call the patient after some time, after 1 hour. You see the cornea is a little hazy, it's steamy cornea, digitally the pressure is high. So what I do is we just put some slight amount of topical anesthetic, take a 26 gauge needle, bend it backwards and just burp it in the side port. You will see. There. That's it. That's all you need to do and the pressure is normal. So the advantage being, because when you're doing a phakic lens, you have two side ports. One is superior, one is inferior. So you always have an inferior side port. So these are some cases, high powered cases. This is one minus 29 with 2 diopter cylinders. This is minus 34. Now this is a corneal scar. This is an interesting corneal scar. Look at the cylindrical power. It's minus 3.5 with 11 diopter cylinder. I'll skip this video. Oh, this is interesting. Now we will see this case. Now, this patient did fairly well. So I've gone in, you can see the corneal scar. I'm fast forwarding the video, put in the phakic lens, 11 diopters of toricity, bang on accuracy. Patient 612 unaided. Now this is again a patient who was roaming around. So I told him that we'll try. This is a patient who was hypermetropic. He was corrected with Symphony. He had a residual power. Anterior chamber was very shallow. So I ordered a phakic lens in plus power for this patient. So this patient did well. Now again, this is another case. Yeah, this is again another corneal scar. This is minus 5 cylinder. Very small scar, but nearly in the center. So again, a phakic lens to correct. Patient did very well. Now you'll see some more interesting cases. Now this is a patient operated by me 18 years ago. Traumatic cataract. Everything is opacified. The lens is stuck up. The lens is stuck up in the eye. It's totally fibrosed. Pupil is stuck up. So what do? I do a little bit of iridotomy. Open the iris and try and separate, create a space between the capsule and see. We have a lens which minus 17 diopters. So this operates.
Sorry, Kamal, our time is already up for the session.
Okay,
we have
sir.
one more speaker.
Okay.
So I would request.
Thank you.